My name is Martin Elliott. I am Chief Commercial Officer of Centillion Technology Limited, a spin-out company from Cranfield University providing a manufacturing platform for a variety of materials, including vaccines. I'm supported by Paul Hernandez from SCI, who will be moderating the question and answer session. We're fortunate to be sponsored today by Appleyard Lees, an intellectual property lawyers company. We thank them for their support. At the end of Professor Ferguson's talk, there will be a question and answer session. Our speaker this afternoon is Professor Neil Ferguson, who heads the Imperial College COVID-19 response team. His research aims to improve understanding of the epidemiological factors and population processes shaping infectious disease spread in human and animal populations. A key practical focus is the analysis and optimization of intervention strategies aimed at reducing transmission or disease burden. Much of his work is applied in forming disease control policy making by public and global health institutions. He was born in Whitehaven, Camberland, but grew up in Mid Wales. He received his Bachelor of Arts degree in physics in 1990 at Lady Margaret Hall, Oxford, and his PhD degree in theoretical physics in 1994 at Linacre College, Oxford. His doctoral research investigated interpolations from crystalline to dynamically triangulated random surfaces and was supervised by John Wheater. It was there that he attended a lecture by Robert May on modelling the HIV epidemic, which together with the death of a friend's brother from AIDS, interested him in pursuing the mathematical modelling of infectious diseases. He was part of Roy Anderson's group of infectious disease scientists who moved from the University of Oxford to Imperial College in November 2000 and started working on modelling the 2001 UK foot-and-mouth outbreak a few months later. He is an international member of the National Academy of Medicine, a fellow of the Royal Statistical Society, and is on the editorial board of the Journal of Royal Society Interface. He is a founding editor of the journal Epidemics. Professor Ferguson has been a regular guest on BBC4's morning programme Today during the last 12 months, and today we welcome him to this Society of Chemical Industry webinar. Professor Ferguson, the floor is yours.
Thank you, Martin, and it's a pleasure to be here, and thank you for the invitation to give a talk. So I'm not going to give a very general talk about epidemiology of infectious diseases, but rather focus on what I suspect most people are interested in, namely the epidemiology, transmission dynamics of SARS-CoV-2 or COVID-19 as it's popularly known. And I'll talk about how that evidence base has evolved in the last 15 months, how it's informed policy, and what are the current challenges and potential risks. Mostly I'll focus on the science, but obviously I'll touch on the policy implications as I go along. So I'll talk a little bit about the challenges of actually doing scientific research in a pandemic, and then review the early science which drove policy a year ago leading up to lockdown in the UK and really across the world. The second wave, lots of the Northern Hemisphere countries experienced really from the summer into the autumn of 2020. Talk a bit about the threat from new variants of the virus, how here I'll focus on the UK vaccination strategy evolved, government planning involved in terms of the combination of both how we roll out vaccine and how we relax social distancing measures, and touch a little bit on some more on the side of technical lessons learned. So and I've worked on lots of infectious disease outbreaks for the last 25 years. Initially in an infectious disease outbreak, inevitably surveillance data, the data we have on the virus typically is poor. And so we start with a very high level of uncertainty, and that only reduces fairly gradually over time. Nevertheless, policymakers need to make decisions, and so we don't have the luxury of just waiting for months until we're sure of conclusions. I mean, perfect really is the enemy of the good here, and we have to do this delicate balancing act of judging the quality of evidence and certainty of conclusions in a timely manner to inform policy making. One of the ways of avoiding groupthink and particular personal perspectives on any one issue is to do what the UK government does and never rely on a single group's input. And that has been true throughout the pandemic, regardless of what you might read in the papers. Boris Johnson did not shut down the country based on solely the model I generated well over a year ago, but on the basis of input from multiple groups across the country. We never have a perfectly coherent picture either. As you've seen in the reporting of science in the COVID-19 pandemic, there's always uncertainty, new results coming out, they don't always agree, but there is generally a kind of broad consensus. And if you review the literature thoroughly rather than cherry picking, then one tends to get a more coherent picture. And where differences emerges, it tends to point to areas where we need to do more research. Focusing down on epidemiology, and what I do, epidemiological analysis, often I'm described as a modeler, but at least half of what I do is statistical analysis of infectious disease data. The very earliest questions when you have a new outbreak is, what are the basic epidemiological characteristics of this new pathogen? What's the incubation period, the serial interval distribution, which is the time between rounds of infection? How severe is the pathogen, the illness the pathogen causes? What proportion of people are likely to die? And answering that question is really quite a challenge, particularly because we know early in an epidemic, milder cases are often massively underreported. How transmissible is the disease, and what's the route of transmission, and therefore what are the patterns of spread we see? What are the risk factors for spread? And then you combine that information into an overall risk assessment to inform policy making, and only then do you look at the potential interventions which can be deployed to reduce, either mitigate or eliminate the risk posed by the pathogen. Transmission modeling, the second half of what I do, the use of computational models to either forecast disease spread or model the impact of intervention options, depends on some knowledge of those earlier parameters I just reviewed. Focusing now on just coronaviruses and a little bit of epidemiological background, it's a very large family of RNA viruses, which in humans, in terms of the endemic coronaviruses, which you and I are typically infected with every couple of years, really causes very mild respiratory symptoms. But like many RNA viruses, it doesn't limit itself to a single mammalian species family. Many other mammalian species are affected by coronaviruses, and the risk exemplified by COVID-19, but it happened before for SARS and MERS, is that these viruses can cross species boundaries. We have these spillover events which go from species like bats or various other mammals into humans. And typically in those cases, they're dead-end infection events. The virus is not well adapted to humans, doesn't spread, but we have seen in the past with SARS and MERS, and now definitely with COVID, that you can have these events where a virus spreads from an animal species to humans and is able to transmit, and that's what causes the risk of a pandemic. Reviewing COVID-19 specifically, I first became involved in doing some work on this around about the 8th, 9th of January, but the first indication we had something was wrong was, as you know, in 31st December 2019, where we had this cluster of cases of unknown etiology back in Wuhan city in China, which was initially associated with a seafood market. That was probably a rather erroneous association. And then very quickly, the Chinese scientists ruled out other causes and identified the virus as a novel coronavirus. Soon afterwards, around 13th of January, the first confirmed case was identified in Thailand. And that was a warning bell to me, because as I'll show in the next few slides, then in order to have a case exported from a place like Wuhan, you have to have really quite a large outbreak for there to be a significant chance of export internationally. The pandemics escalated dramatically from there. China locked down 23rd of January, but by that time, many other countries had been seeded with infection. I don't go beyond 13th of February here, but the WHO declared this a public health emergency of international concern on 31st of January. So faced with that sort of rapidly progressing threat, I mean, the early challenges we faced in terms of characterizing the new pandemic as it was emerging is, first of all, identifying what the true scale of the problem is, trying to put that into context. If it really was only 40 cases, then it's plausible that might have been caused by zoonotic exposure from an animal reservoir, but if it's much larger, it's likely to be down to human transmission. If we're seeing human-to-human transmission, how fast is that virus spreading? And then how much of a threat does it pose? And that's really a question of severity, how lethal is the virus? And finally, we get to the question of really what can we do about that spreading virus? In terms of the first of those questions, what we'd seen by 16th of January was 41 reported cases in Wuhan, but 3 cases discovered in travellers to other countries. And you can do a simple, I won't go through all the details, but simple statistical calculation which says, what is the chance that any one infected person in a city like Wuhan in China would have travelled overseas? And if you do that calculation, you come up with about a 1 in 600 chance, or even less, which means that for 3 cases to be discovered out overseas, you would really have expected something like 1,800 people to have been infected in Wuhan. The chance that if it really was only 41 people infected by that date in Wuhan, that you'd get any international exports would be very low indeed. And we updated that sort of simple calculation several times, but by 3rd of February, we estimated there were over 100,000 infections in Wuhan, way higher than official case numbers. 10 to 20-fold under ascertainment of cases was our estimate. And the reason for that is that the Chinese had limited testing capability, and they were basically only testing people who were hospitalized. And as we now know, only about 2 or 3% of people infected with this virus end up in hospital. I mean, the second question is then, how transmissible is the virus? And everybody in the country, I think, has heard about the R value, what is the reproduction number of virus, the number of secondary cases one case causes at a particular point in time. At the beginning of an epidemic, it's called R0. And we need, for a virus to be able to spread in the population, it needs to be greater than 1. You need to have a multiplier effect, that you get this chain reaction of spread. And from the early case data in Wuhan, and this is the case data we had, and importantly, I should say, this is not just the cases by date of report, where there's many biases, but by the date of symptom onset in those cases. As of 29th of January, this is the data set we had from China, and you can see this exponentially growing epidemic. The kind of more recent time points on the right-hand side of the graph are going down, largely because of reporting delays. And so early on in the epidemic, we were seeing a doubling time of every really 4 to 6 days. I have to say, by the time the virus got to the UK and Europe, it had already evolved to become more transmissible, and we saw closer to a 3 to 4 day doubling time in the early UK epidemic. But this sort of rate of growth gives you an estimate of the reproduction number of about 2 to 3. To put that into context, that's higher than we see in pandemic influenza. It's a relatively transmissible virus. I have to say, with the new Kent variant, B117 variant, which now dominates across Europe, started here in the UK, that's 50 to 70% more transmissible. So we're thinking about reproduction numbers closer to 5 for COVID now. Coming to the other key question, which is how lethal is a virus? That's actually quite a difficult question to answer. Typically, if you just look at reported case data, I mean, that you quantify it through the case fatality ratio, but that depends on who's tested. Early in the epidemic, with limited testing, limited capacity in China and other countries, generally only relatively severe cases were being detected. And so in that context, you would measure a relatively high case fatality ratio. But what we really want to get at is the overall infection fatality ratio, the proportion of everybody infected who will die. And that requires a good estimate of the kind of hidden bit of the iceberg of the proportion of everybody being infected who are not even showing symptoms. And that is quite a challenge to get at early on in an epidemic. I think in retrospect, did a reasonably good job. We used a range of data sources, and we were particularly helped by the fact that Western countries repatriated their citizens from Wuhan early in the epidemic. But when those planes landed, everybody on board was swabbed. And we realized at that point, given we were detecting 2 or 3% of the of those people returning on the planes infected, that there had to be a lot more infection in Wuhan than the official case numbers reported. That gave us a baseline with which to estimate severity. The other source of data was some data from cruise ships, that the populations of passengers on cruise ships is a highly biased representation of the population at large. And so we came up with an initial estimate that for symptomatic cases in China, there was probably a case fatality ratio of 1.4%, but that half of the people being infected probably were asymptomatic. And therefore, overall in China, we estimated the infection fatality ratio at about 0.7%. China is a younger population than the UK, though. That translates to nearly 1% in the UK. But it was very age specific. I should say these estimates we came up with around mid-February, late February. They were kind of finalized late February. There's a steep rise. In fact, the risk of death rises exponentially with age to something, akin to a 10 to 15% risk of death if you're infected if you're over 80, but a much, much lower risk, as we all know now, if you're younger. And to put that into context, it's broadly comparable with Spanish flu, a little bit lower, but of course back in 1918, we had many, medical science was much less advanced, and so we had much poorer treatments in hospitals. And we've, of course, revised these estimates as we've gone along, but if we look back at the history of the epidemic in the UK, where now, unfortunately, 125 to 140,000 people have died, and it's very consistent with those early estimates. We estimate somewhere between a 0.8 and 1.2% infection fatality ratio. So we then moved on to then knowing how transmissible, in the first ballpark, the virus was, knowing how lethal it was, what could we do about it? And here we benefited from the fact that there had been quite a lot of work for respiratory viruses, particularly pandemic influenza, back in the early 2000s, on what would we do in response to a highly lethal influenza pandemic. Early on, we don't have drugs or vaccines available, so we'd have to rely on what are called non-pharmaceutical interventions or behavioural and social interventions. And there are some well-established types of those. First of all, avoiding people who are symptomatic going out and mixing with other people is key, isolation in the home. Then potentially, because people in the same household as an infected case are much more likely to be exposed, quarantining the whole household. And then you can think of other measures, closing schools and universities. Young people have much more intense mixing patterns, and for other viruses have been key drivers of transmission, less so we know now for COVID. Stopping mass gatherings, stop super spreading events, but probably doesn't have an enormous effect on population level transmission overall. And then we have the more economically and socially disruptive measures of social distancing of the entire population and so-called shielding of those who are particularly vulnerable. And this work was pulled together in a set of studies. First of all, our famous report 9, Impact of Non-Pharmaceutical Interventions to Reduce COVID-19 Mortality and Healthcare Demand, and a parallel study by the London School, headed by Nick Davis and John Edmonds, which came to very similar conclusions. A lot of that work was based, I just want to take you back, on models which were fitted to data on the effectiveness of those interventions when applied to influenza. And I did work all the way back in 2007. Martin Bootsma, with a number of groups, looked at this, which reanalyzed data all the way back from 1918 in different US cities, where some US cities, pandemic influenza, Spanish flu swept across the United States in much the same way as COVID has done. and media reports again spread, and there were reports of mass fatalities in New York, one of the worst affected cities in 1918, which influenced policies further into the United States and in the South. And therefore other cities, St. Louis, Kansas City, which were affected later, learned lessons from what New York and Pittsburgh and other cities in the East Coast had seen and locked down. And they saw the same effects of lockdown. I mean, it reduced transmission, but of course they saw the same economic consequences as well. So quite quickly, people were reacting against the interventions, saying it was crippling their livelihoods, and they were lifted. And then they saw a resurgence of transmission. So you see these very clear double peaked epidemics, which are aligned with the timing of these interventions. And it was these data, plus data from what actually happened in China after they locked down, which informed the parameters used in models to model the impact of non-pharmaceutical interventions on COVID all the way, a year ago. So there are two basic policy options we looked at. One is called mitigation. Here we're using non-pharmaceutical intervention, to not completely stop the epidemic in its tracks, but to reduce it to the maximum extent possible, but still gaining enough population immunity that we only have a single wave of transmission. I mean, potentially you can do a lot in that. You can reduce the peak of healthcare demand by maybe 2/3, maybe reduce deaths if you really can successfully shield the elderly population, which I have to say no country has ever achieved, but in theory, if you were able to do that, you could reduce deaths by maybe a half. The problem with this is we were still faced with estimates of healthcare demand and mortality, which would dramatically exceed healthcare capacity in any country of the world, particularly in the UK. We estimated there would be a kind of 8-fold, the demand would exceed capacity in terms of intensive care beds by at least 8-fold. And this is where the kind of estimate of 250,000 UK deaths came from. That was never, that estimate was assuming we would do everything short of locking down and suppressing transmission. So suppression is where you don't try to kind of manage an epidemic, but still let it run through the population, but you try to reduce the reproduction number below 1, the R value, and stop an epidemic in its tracks. There we estimate, China had already demonstrated it was possible to do, and then Italy thereafter, but we always knew that it was a completely draconian policy option. It would likely be effective, and it would be effective about 3 weeks after it was reduced. You would then see the curve turning over in terms of hospital admissions and deaths, and it would work in terms of reducing healthcare burden. But because the virus is still there in the population, it's hard to eliminate, that would take many months of lockdown, you're still faced with a policy option where it works as long as it's in place, as was seen in those US cities in 1918. But as soon as you relax the intervention or lift it entirely, you would expect transmission to resurge. And that's exactly what we have seen, and that's the history of the last 12 months. If you're applying suppression measures or lockdown, I should say lockdown and suppression are two distinct things. Suppression is your policy goal, suppressing transmission. How you achieve it can be achieved in a number of different ways. Lockdown is the fastest way of doing so, probably the most effective policy, but other countries have achieved that without full lockdown. Sweden is often pointed to as an example of a country which didn't lock down, but achieved suppression, albeit at a cost. It had 5-6 times more deaths per capita than its neighbours. If you were going to adopt a suppression policy, acting earlier saves many lives. And that's unfortunately a lesson which was not always learned in this pandemic. We always anticipated in that early report that because of the fact that lockdown suppression measures only work when they're in place, that there would be pressure to then relax measures, and then we'd see a resurgence of transmission. So we explicitly looked at that. We looked at actually a more mechanistic, algorithmic triggering of interventions based on hospital demand than was actually ever implemented. What ever got implemented was was a gradual relaxation of measures and a gradual reimposition of measures due to politics, economics, and many other things. But we always anticipated that you would need to lock down multiple times until we had vaccine. And that's the fundamental problem. I mean, we needed this policy in order to prevent health systems being overwhelmed, never mind the many hundreds of thousands of deaths which would be seen. And it worked as intended at least in high-income countries which implemented it, but it was hugely economically costly. And we always knew that would be the case. I mean, it really was a last resort rather than a first policy option we reached for. But the challenge is, if you just lift the measures without something to put in their place, you risk all the gains being made just being lost, and another resurgence of transmission which would kill just as many people as if you'd never locked down in the first place. So the only alternatives to that is try to control individual chains of transmission, and that was the policy, really from about May onwards in the UK, focusing on building up a test and trace capacity, cluster detection, local lockdowns. And I mean, that had some success over the summer, but clearly we had the infection levels overall were too high to allow test and trace to ever be as effective in this country, to ever be as effective as it was, for instance, in Korea or Taiwan, when you can deploy enormous resources to track down every case if you only have a handful of cases. And there were always intrinsic limitations to track and trace based measures. This is a nice paper published by Adam Kukarski at London School. We've done similar work which tries to quantify how effective contact tracing can ever be for COVID. And what we know is, from the knowledge of the biology of this virus and its epidemiology, is if you isolate symptomatic cases, you can reduce R by about 25–30% if you do that promptly. Quarantining households on top, immediately somebody becomes symptomatic, can that raise that to an overall 35–40% reduction in R. And if you manage to do what, for instance, South Korea and Vietnam did through very intrusive and very intensive measures, contact trace all external contacts outside the household, you can achieve something like a 55–65% reduction in the reproduction number. That becomes close to, before we had the new variant, what is able to control transmission of this virus. And that explains a lot of why South Korea and Vietnam, with strict border controls and very intensive contact tracing, were able to limit case numbers to quite low levels compared with Europe. But the UK was seeded with far more infection. All European countries were seeded with far more infection than South Korea and Vietnam were. And therefore, were faced when they first locked down with dramatically higher infection levels, and we never drove infection levels low enough to do South Korea, Vietnamese type contact tracing. And so we were limited to household quarantine, one-third roughly reduction in transmission, and that was never going to be sufficient to control transmission of this virus. And that was the problem we faced last autumn. As you know, I mean, countries across Europe have seen the second wave of transmission starting with a low point after the first lockdown in August, early September of last year, and then ever increasing transmission thereafter at different levels. This graph, I should say, is deaths per million, and it's on a logarithmic scale, but it shows actually, if you, the broad qualitative picture between different countries in Europe has been really remarkably similar, even if the absolute numbers of deaths have been different. They've been seeing the same epidemiology. I mean, there have been many improvements. The infection fatality ratio in the second wave of the epidemic, at least until we got the new variant in the UK, was lower. It was reduced by half by improvements in treatment and clinical care. But it just goes to show that, I mean, it was entirely expected, and we predicted it well over a year ago that there would be a second wave of transmission once we relaxed the first lockdown. The political challenge in responding to that, despite the fact that all the epidemiologists and people advising governments across Europe knew this was inevitable, knew what needed to be done to control it, namely basically repeating what had been done in the spring, albeit with nuances. And I mean, second lockdowns were not as draconian as the first lockdowns, and we did have test and trace, which helped, but nevertheless, across Europe, politicians were slow to act. the lessons were not learned about the importance of locking down early, and the fact that there isn't really a trade-off between the economy and controlling this virus, that if you respond to increases in case numbers earlier, you keep infection levels lower, you save lives, and you can lift measures earlier, so the overall economic impact is no worse. But there was lots of I mean, the political consensus had fragmented across Europe. There was lots of noise in that popular discourse, skepticism about science and government, which is what the Wellcome Trust figure on the right-hand side represents. People were tired of lockdown, and they'd seen the cost lockdown. We always knew what the cost of lockdown would be, but they'd seen in their own lives what the cost of lockdown was economically and socially, and were reluctant to go back to it, understandably. And so it was only really when hospitals started filling up again that politicians felt they had the political capital to really act. And that is a tragedy, really. We were modelling this throughout in terms of looking at, the effect of local policies. And so a lot of our time spent last autumn was seeing how effective was the tier system. And it was effective. It did slow growth. I mean, the growth of the second wave until the new variant came on was much slower than the first wave. We were having an effect. It just wasn't fast enough. This shows the comparison between sequential weeks predictions generated by the SPI-M advisory group to SAGE compared with data. So the predictions in blue, we fitted to the data in red in each week. And then, I mean, we were getting quite good at projecting the trajectory of the epidemic, but it was always on an upwards trajectory. And the fundamental problem of a local control policy, particularly as it was adopted in the UK and many other countries, is that basically politicians responded to how high infection levels were, how high case numbers were, not to the growth rate of the epidemic. And so what we were doing last autumn is letting every area of the country get up to a high level of infection, because only once a high level of infection was reached were areas moved up to a higher tier and control measures intensified. And that meant going into what was the second national lockdown in November, the whole country had quite a high level of infection. We've been modelling this throughout using a variety of models, the initially individual-based simulation I coded many years ago, moving to a more bespoke model, which is more suited to tracking an epidemic in real time. All of these are so-called susceptible, exposed, infected, recovered models. And they're quite sophisticated in how they try to model not just the incidence of infection in the population, but exactly what happens to people who are infected, the risk of hospitalization. This is represented by the diagram on the right-hand side. We also fit this, the UK real-time model, to not just a single data stream, but many different data streams. I mean, pillar 2 cases, what gets reported every day, hospital admissions, bed occupancy, deaths, and then other data on serological testing done by PHE, a proportion of people with antibodies, and infection prevalence surveys like ONS and the Imperial React study, with many different goals. I mean, first of all, we generate the weekly R estimates you hear reported, projections for government of what likely trajectory of the epidemic will be for the next few weeks, and then evaluate specific policy options. And so this gives an example of fitting this sort of model back last year up till data in August to that serology data on the top, proportion of people with antibodies wane over time, I should say, and then to just 2 data streams, deaths in hospitals and deaths in care homes. And then, this is work we did back last autumn. We're looking at the potential effect of a second lockdown in November to December, and then how might transmission resurge under a variety of assumptions about what measures then were put in place after the lockdown was lifted in early December. And then on comparing the left-hand side with the right-hand side, sorry, the top row compared with the bottom row, how much social contacts were allowed to increase over the holiday period, Christmas relaxation of measures, and then comparing the left-hand side with the right-hand side, whether we would need a January lockdown. It was always anticipated that it would be quite likely we would need another lockdown in January. And I should say all of this work was done before the UK new variant was recognised, and that changed the picture substantially thereafter. this shows the emergence of that new variant. So here you're seeing a phylogenetic lineage, a tree on the right-hand side with all the different strains of COVID since its emergence in Wuhan in end of 2019. And you'll see in a moment the orange bit at the top is the emergence of the UK new variant, which spread very rapidly in this country and then thereafter very rapidly across Europe and now dominates across the entire continent. The reason the other European countries are seeing a resurgence in transmission right now is exactly the reason we saw a resurgence in transmission in December last year. It's the increased transmissibility of that new variant. And so I was hoping to take 2 weeks off over Christmas, but I spent the entire Christmas holiday with many colleagues of mine in the team here at Imperial trying to analyse data on the new variant to inform government policy at the time. So most of what we were doing in December. And what we saw when we dug into the data, fortunately, the nature of PCR testing in the UK is such that we were able to distinguish in about a third of people tested between the new variant, the Kent variant, and the old variants of the virus, whether they tested positive on the S gene, so-called spike protein, through PCR testing. And what we saw, and these are the graphs on the right-hand side, these plot overall case numbers, the thick line at the top of each graph, and then for the ones we could type, the variant in orange and the old variants in blue, what was happening last year. This is by epidemiological week of the year. And the pink area in each graph, the left-hand pink area is the second lockdown in November to December. And then the pink area on the right-hand side is the third lockdown the UK imposed. The difference between those lockdowns is schools were open in that second lockdown, but closed in the third lockdown. And what we saw in the second lockdown was, whilst the old variants, the blue curves are always going down, that even during the lockdown, this new variant was expanding. And that's a clear signature that this new variant was more transmissible than the old variant. And then, of course, when we came out of that second lockdown, transmission really took off until Tier 4 and the third lockdown came into place in the Christmas holidays. So we saw a catastrophic increase in cases. The frequency of this variant, the proportion of all COVID cases which were the variant, I mean, it spread geographically across the country. It took off in the plot on the left-hand side, in the east of England, southeast, and London first, but then rapidly spread thereafter. And now is dominant across the UK, indeed, as I said, dominant across Europe. And so we spent a lot of time crunching the numbers on that variant to estimate exactly how much more transmissible this variant was than previous variants, and came up with an estimate of between about a 50 to 80% increase in transmissibility, depending on setting, and it varied a little bit over time, depending on what other control measures were in place. But the best guess is it's about 70% more transmissible. And that's a huge increase. It's the difference between a basic reproduction number of, of the order of 3 and a basic reproduction number of 5, and makes control of this virus much more difficult. We also, and in the interest of time, I'm going to zip through, I'm not going to go into the details of this. I mean, London School really did most of the work on this. We did some confirmatory analysis, but we have some data to suggest that this virus is also, this new variant is also more lethal. And coming to the overall summary of the results, we think it's about 50% more lethal than previous variants. Just look at the top row of this table using 3 different measures. What I'm estimating is how much higher the infection fatality ratio of the new variant is compared with of the previous strains. And overall, we were coming up with numbers of the order of about 40 to 50% more lethal. This analysis now a little out of date. It was done early in January, but informed, again, government announcements at the time around the increased lethality. And it's one of the reasons, this combination of increased lethality and increased transmissibility is why some 60% of all deaths we've seen in the UK from coronavirus have happened in the last 4 months due to the new variant. So the current situation, though, is looking a lot more optimistic after that catastrophically increasing case numbers in December, peaking at some, 1,200 deaths a day. The third lockdown, combined with the rollout of vaccination, has drastically reduced case incidence and transmission of the virus through all the metrics the government plots and releases every day: cases, deaths, patients admitted to hospital, and also in terms of the rollout of the vaccine. And the only risk at the moment is that since we've now reopened schools, we're still in lockdown, reopened schools, as we had anticipated, as I commented back in the second lockdown, that's probably not sufficient to control spread of the virus on its own. So we're seeing case numbers plateau. But because we've rolled out vaccination, which has protected people from severe disease, we're still seeing deaths and hospital admissions drop. And our long-term way out of this, the solution is really vaccines. And 3 are licensed in the UK at the moment, 2 are being commonly used, the AstraZeneca and the Pfizer vaccines, both of which probably offer at least 80% protection against hospitalization, probably something like 50 to 60% protection against infection. So these are highly effective vaccines, particularly against severe disease. Effectiveness against preventing deaths may be higher still, but they're not 100% effective. They don't completely block infection, they don't completely block transmission, they don't even completely block severe disease. And so we do have this trade-off that as we roll out vaccine, we protect people, but not perfectly, and we still have the potential of transmission, which brings us into this issue of the UK roadmap and the government being now finally relatively cautious in relaxing measures, because we're in a situation where we've been very successful at rolling out vaccination faster than almost any other country. But still at this point, we're probably only in a situation where about 30% of the population are effectively protected. We're up to about 45% who've had a first dose of a vaccine, but the vaccine is not perfect. And it will take until the summer for us to get up to about, of the order of 60 to 70% protection of the population in terms of potential reduction of transmission. But with a virus as transmissible as this virus now is, even that isn't potentially enough to completely block, give herd immunity and stop transmission overall. So we have this trade-off that what the government is trying to do is relax measures as fast as they can, given their knowledge of how quickly vaccination is being rolled out and how effective that vaccination is, both at reducing severe disease and reducing transmission. And there's a lot of uncertainty involved as well. So this is what we are trying to model. We model a kind of relaxation of measures represented by how much we expect the basic transmissibility of the virus to increase in the presence of interventions over time if there was no immunity. And then we layer on top of that, on the right-hand plot, how much we expect the vaccine rollout to reduce that transmission, reduce that transmissibility of the virus in terms of the reproduction number. And then we can map that onto, using the transmission model, onto what that translates to into a predicted epidemic trajectory, represented in terms of hospital bed occupancy or cumulative mortality. And so what we expect to see in the next few months, and I haven't labeled these scenarios, none of them are precisely what the roadmap is, but we're hoping to be somewhere in the lower end of that, maybe between, well, I have to say the yellow plot probably the yellow curve probably most closely resembles the roadmap trajectory given our current estimates of how effective the vaccine is. So we expect to see gradually increasing case numbers in the next few months as we relax measures. Inevitably transmission will resurge to some degree, but it will be manageable. There is a risk of a third wave of transmission in October. We expect it to be less than we saw in both the first and second waves, and hopefully that can be mitigated. First of all, there's a lot of uncertainty around it. It could be very small, but we hope it can be mitigated with updated vaccines and boosting immunity of the population come the autumn. But there is an enormous amount of uncertainty in these projections. We can't precisely predict what the impact of particular policy interventions will be. There's a lot of uncertainty around how seasonal transmission of this virus is, and we don't know how quickly immunity will wane, both natural immunity and vaccine-induced immunity. And on top of that, there's risk from additional new variants. And so we need to be really driven by what the data is showing us as we relax measures before we go on to the next step. Current concerns are around kind of new variants. We've done a lot of work, and this is what I'm showing on this plot here, on looking at the Brazilian new variant, which probably is a partial escape variant, by which I mean it probably partially evades immunity generated against current vaccines or against natural infection. But actually the South African variant probably escapes even more from recent data and is much more concerning even than the Brazilian variant. The risk here is not that these variants are any more transmissible than the virus we have in the UK at the moment. They're probably not. But if they've evolved antigenically, if they are able to evade immunity even partially, then that risks undermining the vaccination program we're rolling out across the country and gives a greater risk of then a much more catastrophic third wave of transmission if these variants are able to infect people readily who've been vaccinated and put those people in hospital, and we have a real problem, which is why, I mean, I in my public pronouncements in the last couple of weeks have been emphasizing the need to try and keep particularly the levels of the South African variant at the lowest we can until we're able to update vaccines. So just to summarize, come to the end of this talk, I mean, we knew a lot really quite early on about how transmissible this virus was, how lethal it was, and that drove early policy. I mean, there was no reason to suppose there was any significant level of protection in the population when the pandemic started out. So we were faced with scenarios of really catastrophic waves of transmission and hospitalizations and deaths, which would overwhelm the health system. I think there are many lessons to be learned, though, both in terms of the policy response and in terms of managing this sort of crisis going forward. I mean, the key technical lesson in my mind is that we, across Europe, but particularly in the UK, we had woefully inadequate testing capacity back in February and March. And so we had this impossible trade-off. Do we try to set up a sentinel surveillance system which really tells us how much infection is truly in the country, and that has to be based in hospitals, or do we focus our efforts on the borders and testing travellers coming back from China and other countries where we know that there was a virus? And we didn't really have enough testing capacity to do both initially. And that meant that we had a very partial picture of how much infection was in the country. We'd always anticipated we would not be picking up every infection. We estimated that we'd missed 2/3 of them coming into the country, but in reality we missed closer to 90%. And so in mid-March we were much further along in the epidemic than anybody had anticipated. I think other key lessons are, I mean, contact tracing is important, but depending on the characteristics of the virus is not necessarily going to be a panacea, particularly for highly transmissible respiratory viruses where a lot of people are asymptomatic. At a kind of broader political level, I would say we always anticipated, I say we, epidemiologists, people advising government, always anticipated we would have a second wave of transmission, but unfortunately politicians felt unable to act. And that's partly down to how polarized and fragmented the political discourse around this virus had become by the autumn, with significant sections of society, including some national newspapers, arguing that the threat had been overblown, that lockdown wasn't needed, there wasn't going to be a second wave, we were just seeing a case-demic due to tech. And that's associated with a quite systematic disinformation and cherry picking by people with that political agenda. All that said, I think overall the global response to the pandemic has been remarkable. I mean, we've had, well, probably in reality twice that many deaths, but over 2.7 million deaths reported, but it could have been far worse. I mean, the world has, despite it being an imperfect response, we have limited mortality to a fraction of what it might have been had we done much less. And that policy response was driven, I hope I've persuaded you, by scientific fundamentals of how lethal this virus was and how transmissible it was. But as we see now across Europe and in this country, I mean, we are all exhausted, and there's been a catastrophic economic cost of the interventions implemented. And so all of this is making effective control difficult. On top of that, the UK was faced with something we couldn't have anticipated or predicted, namely a highly transmissible and more lethal variant which arose within our borders, most likely. On the positive side, vaccination is looking very promising, both in its effectiveness and in the UK terms and speed of rollout, and does offer our long-term exit strategy from lockdown and the social and economic costs of that sort of policy. But we need to remain vigilant. I'll stop there to allow a little bit of time for questions.
Thank you very much, Professor Ferguson, for such an interesting talk. And we have a lot of questions, so I'll just start with one of mine, and then we'll move on. So you've briefly touched on the skepticism that society can have sometimes about science with scientists. What do you think are the key lessons learned from this whole year, or a bit more than a year? And what do you think scientists can do to try and regain that trust that might have been lost?
So I actually think trust in scientists has increased in the general population in the last year rather than decreased. But I think, the term post-truth politics has been often used. We are in a media age, and a particular social media age, where we're seeing increasing polarization, and something which we didn't see 20 or 30 years ago, which is there is no norm in terms of evidence. People, if they choose to, can get all their news from Fox News and live in a bubble which is isolated from the rest of the world. I have to say the same can be. It's not a particular criticism of the right necessarily. It's easy to just choose a certain set of media outlets which reinforce the opinions you already have. Perhaps a more worrying thing on top of that, that's always existed to an extent. There's always been some tribalism in politics and in people's beliefs. But social media has amplified it and has also moved us to a point where the idea of fact-checking, of a common and evidence-based, common base of truth we all believe in, has fragmented. And Trump exemplifies the problem in the United States. I don't think the UK has ever got to that situation. But we've always had a small tendency, a skeptical tendency in this country against climate change, against controls against tobacco, against other things, who have been contrarians against mainstream evidence. That's just got worse. I think it's problematic where people start from an ideological viewpoint and then seek out, cherry pick evidence to support that viewpoint. And I think mainstream scientists can just resist that by communicating science clearly. I don't think generally we should be involved in the political debate. We are members of society, but it's not our role. All we can do is clearly trying to communicate the science as we see it, and actually be self-critical ourselves. So I've learned things in the pandemic. Not every assumption we made first on, and you have to accept that, the evidence base will change. There will be some assumptions you made earlier on which were wrong, and one has to own up to that.
So we'll move on to questions from the audience. So Stefan Ortulik asked, what proportion of the population do you think is immune due to having had the virus rather than being vaccinated at the moment?
Right now across the UK, it's probably somewhere between 25 and 30%, probably closer to 25% have actually had the virus. It varies by age. And then that overlaps, of course, with the proportion who've been immunized, but we think we're getting up to about 40%, 45% immunity in the population.
We have a question from someone that is probably looking forward to escaping and having a little break. They ask, when older people are fully vaccinated, will it still be risky to travel overseas by air later this year?
So I said it will depend on the vaccine. So the mRNA vaccines, the Pfizer and Moderna vaccines, after 2 doses, offer probably something like 95% protection. So it's not 100%, but it's very high. And they almost certainly will give still a high level of protection against the South African variant, maybe not quite as high, but still high. We don't know how long-lived that protection is, but it's likely to be 6 months, a year at least. Though other vaccines, most notably the AstraZeneca vaccine, there we think probably protection against at least severe disease is capped about somewhere between 80–85%. So there's more, it's good, but there's something more of a risk. And we know vaccine efficacy for the AstraZeneca vaccine drops by a larger degree against the South African variant than perhaps other vaccines. So I think it will be down to personal judgment as well as government advice as to what, particularly if you're in a vulnerable group, you do after being vaccinated. All I would say is that it will get more and more positive. We will get better vaccines by the autumn. Vaccines will be updated and the levels of protection will increase. Do you think that companies will be able to churn out to make and renew and update those vaccines? I mean, that's already happening. So both the AstraZeneca team, Pfizer and Moderna are updating their vaccines. I mean, Pfizer and Moderna and actually the Novavax vaccine probably will offer very high levels of protection even against the South African variant, just not quite as high. It's possible the AstraZeneca vaccine, whilst it doesn't offer enormous protection against infection or mild disease for the South African strain, it probably still offers reasonable protection against severe disease. It just won't be as high as 80%. There's a common theme across many questions, and I'll just summarize by one, but talking about the new normal and the long-term consequences. I'll pick one. So do you foresee social distancing being a long-term new normal for society, and how? So, I mean, I'm not a behavioral scientist. I'm an epidemiologist. So how individuals and populations respond to the last, I mean, very traumatic 15 months is an open question in my mind. I'm sure it will take people quite a while to get back to normal. We actually saw that last summer when social distancing was relaxed and the original lockdown was relaxed. It took people months to actually take advantage of the opportunities they were given. People were very conservative in terms of managing their risk. And it was only really by the August that we saw a significant uptick in contact rates. I suspect we'll see to some extent the same again. And yes, it wouldn't surprise me that some people remain more cautious going forward. Thank you. And I think we'll need to ask the last question because we're running out of time. Yeah. So Jim Bullock asks, for understandable reasons, we're vaccinating the people who are vulnerable, but don't mix much. But we haven't vaccinated yet those that mix a lot, for example, children and younger working adults. They're wondering, what if we'd done it the other way around, i.e. vaccinated the mixers first, dampened community transmission and kept the more vulnerable locked down for longer? So we looked at that. And with the projected speed of rollout, which is really determined by vaccine demand, the vaccine supply rather, then it was always optimal to protect the vulnerable first. If we'd suddenly got a much higher supply of vaccine, then there are a few instances where it's optimal to do it the other way around. It should be said that young children are not key transmitters of this virus. You probably target teenagers, but the trials have not been finished in teenagers, so we restricted the adult population. But basically, it was all the analysis of what we've done and that other groups, Warwick and feeding into JCVI, have done, would suggest that targeting going from the highest risk people to the lowest risk was optimal. And that's just because the risk of death increases exponentially with age. Thank you very much. So that is all for questions. I'll hand over to Martin to close the session. Thank you again.
Thank you, Paul. Thank you, Neil. I found that to be a highly illuminating and informative talk this afternoon, particularly your view upon future scenarios, concerns, lessons and conclusions. Particularly, I would thank you for the career advice about not entering politics as a scientist. I think that's very wise. To the SCI team who have been responsible for putting the SCI talks on, I thank you all. And I thank all of you in the audience for attending. You've seen the advantages of becoming an SCI member. If you aren't, I really would suggest that you consider it. It's very good expense, something that I have definitely benefited from myself. We have a series of other talks coming up fairly soon about COVID, the robotic alchemist. Dame Jocelyn Bell Burnell will be talking on Wednesday the 28th about interstellar chemistry, and then on Wednesday the 26th of May we will start to learn about how human vision colors the world from Professor Anya Herbert. And with that, I'll once again say thank you everybody for your involvement, and we look forward to seeing you again at one of our future SCI talks. Thank you very much indeed.